Thank you, Javier, and thank you, everybody, for coming to hear me talk today and for making time to hear me speak. So I thought that I would begin by talking a little bit about the variety of projects that I have worked on over my career. As Javier mentioned, I started my career at Boston University in the MPH program, and I went there expecting that I was going to look for a career in health education and program evaluation. And while I was there, I started doing research for one of my professors, and to my surprise, I discovered I really loved research. She had a project that was looking at alcohol abuse and injury among Army soldiers, but she also had a project looking at stress and health outcomes among soldiers who had deployed to Operation Desert Storm. And it was in the course of working on that project that I became really interested in the intersection of science and politics. There were, at the time, a lot of veterans who were very, very angry at what had happened to them in the years when they came back from Desert Storm and felt that the government had not adequately listened to them about what they thought about how their service in the Gulf affected their health. So it was really kind of an introduction to me in how science and politics can sometimes spark public controversies and can make the creation of scientific knowledge and the execution of science itself really difficult. So when I decided that I wanted to pursue additional training and become an independent researcher, I decided to pursue a doctorate in sociology at Brown University, where I worked for a person who was studying what we called health social movements and contested environmental illnesses. And he was actually looking at what the Gulf War veterans were saying about how the service in the Gulf had impacted their health. And he was using the tools of a social scientist to understand how those controversies impacted the way soldiers trusted the healthcare system and trusted the government to do this research. So I did a lot of work with him on health social movements, but I also became interested in trust at a lower level of analysis, looking at how doctors and patients communicate together and how patients make decisions about technologies and treatments where there's some sort of a controversy about them. So my master's thesis for my sociology degree looked at doctor-patient communication around vaccinations. I also pursued a lot of work on environmental health and social justice, looking at communities in Rhode Island that were facing some sort of contamination, either from a polluting industry or because they were situated on some sort of a toxic waste dump. And again, looking at how communities mobilized to try to press for redress of their situation and get cleanup or get policies implemented that would protect their health. And then my dissertation research was looking at the epidemiology of gene-environment interactions. And I presented some of that work here maybe a year and a half ago, so I'm not going to go into any detail about that today. But in brief, what I was looking at was how epidemiologists who are studying the interplay between genes and health face and overcome challenges in their work. So how do they collaborate across interdisciplinary lines? How do they get funding to support their research? How do they get data? How do they conceptualize the environment and then go about collecting data that will help them operationalize that? So I won't go into anything about that today, but that project sort of sparked for me a set of questions about, well, what do we know? What do we do with what we know about epidemiologic research? And in the wake of all this new information that's coming out about gene-environment interactions, how are state policymakers or healthcare administrators responding with new kinds of programs and policies that will bridge the research and practice gap? So here at the University of Wisconsin, I've been investigating and starting a project that will look at state-level public health policy and what I call the politics of research translation. So, understanding that there's a gap between basic research and clinical practice and looking at how that gap poses a barrier in terms of political structures, social structures, things that inhibit the translation of science from knowledge to practice. I do also have a smaller project that I am just launching about community mobilization and the cleanup of contaminated land in Milwaukee. I won't be talking about that project at all today, but I'm happy to answer any questions you might have about it, or we can talk about it individually. So when I think about my research program, I know I sound like I'm a little bit all over the map, but to me, these three currents of research sort of all come together around questions about risk. So how do experts debate meaning about risk, and how do we study risks and exposures to risks? But also, how do people make decisions about risks, and how does trust in the scientists and the government agencies that produce information about risk affect the way people feel about new technologies or healthcare? And then when communities are subjected to risks, what do they do with that information? How do they organize and mobilize to protect health and social justice? So as I said, I just got an ICTR Type 2 pilot grant that is going to help me look at the cleanup of contaminated land in Milwaukee. That sort of falls into this part of my research on environmental health and social justice. Won't spend any time talking about that today. What I'll instead talk about is my new NIH grant. I just got a K01 award funded that will allow me to study this idea of the politics of research translation. And the vehicle that I'm using for it is looking at what states are doing with their genetics programs in their state public health agencies. So, you know, one of the things that was exciting to me about coming to Wisconsin was the presence of the CTSA here and, you know, the Institute for Clinical and Translational Research. And I know there's a lot of interest here about research translation. And as a social scientist, I think it's worth reflecting on how we do what we do and why we do what we do, so that in the attempt to migrate science from basic science to actual clinical practice, we have some way of thinking about whether or not what we're doing is working. Now, I know that in NIH parlance, the common framework that people use is Type 2, Type 1, or Type 2 translational research, thinking about it as a two-stage process. So Type 1 research gets you from bench to bedside. Type 2 research would get you from bedside to the community. This is an alternative framework that has been proposed by Muin Curry and his colleagues at the Centers for Disease Control. And one of the things that they argue is that thinking about it as a two-stage process doesn't really allow consideration for the full range of kinds of knowledge transfer that need to happen in order to migrate something from science to practice. And it doesn't engage questions about the range of institutions and organizations that need to be partners in that practice. So that, you know, we should, for example, look at things that hinder the process of guideline development. That's as important as, you know, the basic science that helps us understand the biological mechanisms of disease. We need to think about implementation and diffusion research, as well as patient outcomes. Now, when we talk about the research translation continuum, and we talk about barriers and pitfalls, there's usually two kinds of problems we worry about. The first is what we call the problem of lost in translation. So this is the issue that new discoveries don't get implemented, or they don't get implemented quickly enough to really benefit all the people who could be helped by them. And there are a lot of examples of this. So, you know, going back to the 1980s, we found out that prescribing beta blockers was really effective for patients who have hypertension in preventing the progression of their disease to heart failure. And yet, only about 2/3 of patients who should be getting beta blockers are actually prescribed them. Only about 1/3 of patients who should be prescribed aspirin are getting aspirin prescriptions. So there are clearly a lot of obstacles in getting information from basic scientists and out into clinical practice. So that's one kind of problem. The second kind of problem that gets some attention is the problem of inappropriate translation. So concerns that things get rushed into practice inappropriately or before they're before they're really ready. There have been many well-publicized instances of drugs getting recalled because of adverse events that weren't detected in the preclinical trial stage. There are also concerns, I think, about people inappropriately using medical technologies to profit commercially before they're really ready or before it makes sense for them to be used widely. And I think that that's definitely been a factor and a concern that has been raised about some of the genetic tests that have become available. So Muin Curry and his colleagues at the CDC have also talked a lot about the need for public health to play a role in this conversation. So they published this editorial in Health Affairs in which they argue that variable coverage and reimbursement policies for new genetic technologies can lead to differential access, exacerbating health disparities. So as new technologies and new treatments become available, we need to think about how they get implemented. Otherwise, it's going to become yet another source of disparity, yet another thing that divides patients and improves the health of some populations at the expense of others. And one of the things they argue is there's an urgent need for collaborative process for the appropriate transition of genomic discoveries from research to practice. So there's a couple of things going on here. One of the things that I think is really important is a very strong voice in public health saying that public health should have a role in these conversations, that we understand the value and the benefit of population health discoveries, and that we should be part of this discussion. So why am I choosing genetics as a vehicle to look at this controversy? So I could have selected any number of research translation challenges, but I decided to look at genetics for a couple of reasons. Now, I think some people are initially surprised when I talk about this, but state health agencies have been involved in genetic programs for decades, most visibly through things like birth defect surveillance or newborn screening. But state health agencies also play a role in assurance, in linking communities to care. So sometimes they'll deliver care through a county health department or a local health department. Sometimes they'll help patients link to charity sources of care that will provide them the care that they need. So they also play a role in licensing healthcare professionals and workforce development. So there are a bunch of things that state health agencies can be doing in the realm of genetics. With this new wave of genetic discoveries, however, state health agencies are facing a number of challenges. One of the first things they have to do is they have to figure out how to evaluate a really rapidly changing body of science and determine its applicability to public health. A second thing that they really need to do is they need to create new programs and policies that leverage that genetic information, but they need to graft those programs and policies onto what they do already in a way that will make sense with the rest of their public health mission. They also need to tailor those programs and policies to the state context that they're in. And it's all well and good to say that states should tailor programs and policies, but we also need to recognize that if states do things that are too different, your ability as a citizen to get services will vary greatly depending on the state that you live in. So this is another source of health inequalities, another reason why we should be monitoring what's happening at a state level. And then finally, in today's environment, every state needs to justify very carefully what they're investing their resources in. And with limited program dollars, they often have to look at building public-private partnerships to promote population health. So another way of thinking about this is according to the Institute of Medicine's framework of core public health functions and essential public health services, if you're familiar with this triad. So this was proposed in an Institute of Medicine report back in the 1980s. And if you think about the core public health functions of assessment, surveillance, so in the upper right-hand corner there of the wheel, monitoring health and diagnosis and surveillance. This is classic public health. This is what we think about when we think about public health. If you saw the movie Contagion, this is, investigating outbreaks of infectious disease, investigating outbreaks of foodborne illness. In the assurance realm, I've already suggested that state health agencies play a role either in providing care or in linking people to care. They also regulate workforce healthcare professionals and assure the competent workforce. They do program evaluation to decide whether or not programs are working, and then they enforce laws. And then finally, policy development is another important area of state activity. So they'll educate providers and the public about new technologies or new regulations that will impact their health. So taking a step forward, how does this matter to genetics? How does this change with new genetic technologies? So in the assessment realm, if we have a new range of surveillance questions now to answer, if we find out that there is a gene for prostate cancer, when, whether, and how should we screen for prostate cancer? Who should be screened? And state health agencies, through their Medicaid programs, will help to play a role in institutionalizing some of those surveillance routines. In assurance, in workforce development, if a need is growing for provision of a new kind of health care, one of the things that's become very important in genetics is genetic counseling. So having a group of healthcare providers who are appropriately trained in how to ask questions about a family history and help a patient decide whether or not they're a good candidate for screening, and then helping them interpret the information to guide decision making. That's a new brand of healthcare professional that's needed, and states can play a role in issuing licenses that will promote workforce development and make it easier for that group to grow. And then in the policy development realm, one of the things that I think a lot of people are aware of is there's a federal Genetic Information Non-Discrimination Act, but there were some limits to that program, to that federal legislation. It only prevented the use of genetic information in certain kinds of discrimination. It didn't, for example, prevent the use of genetic information in discrimination in workman's comp. But a lot of states have started to pass laws that prevent that. So one of the things that's interesting to watch then is how do states cooperate and share information about drafting new policies or drafting new legislations? You know, does every state take up the challenge themselves, or do they just share copies of legislation amongst themselves? So this is a way of understanding the core public health functions, what public health is and always has done, and how it's going to have to respond, or how it is responding, to new genetic information and new genetic programs. So I've just received a K01 award from the National Human Genome Research Institute that's going to allow me to study these questions a little more systematically. So the first step that I'll be taking is just to characterize public health genetics programs in 5 different states, just starting by describing the conceptual models, the organizational structures, the financing mechanisms that states are using to support these programs, and helping to understand the heterogeneity that's out there. The second thing I'll be doing is documenting the opinions and the attitudes of stakeholders that are about those programs. So, as I said, with limited program dollars, every state agency is working very hard to foster public-private partnerships. And what I'm interested in knowing is how does the configuration of those partnerships and the range of stakeholders that get drawn in affect what states ultimately end up doing. The second part of my study is going to be finding a way to explain variation across states in what states are doing. So I'll be looking at how genetics programs vary under different kinds of structural arrangements. So does it matter how it's financed? Does it matter where it's situated within the state health agency? And then finally, what I'll be doing is trying to identify the critical organizational and structural elements and the financing mechanisms that impede or promote integration of genetics into public health. So these are my 2 specific aims, and this is really kind of what I think of as the heart and soul of this project. So I'll give you some examples then, some more specific examples of what states are doing so that you can understand how they vary. When we think about something like newborn screening, you know, this is one of the historical examples of genetics in public health. Every state has a newborn screening program where they screen infants for a range of metabolic or genetic disorders. Now, historically, what has happened is at the federal level, there's a Secretary's Advisory Committee on Heritable Diseases in Newborn Children. And as new information about new genetic tests becomes available, that committee screens that information and decides whether or not it's valuable in protecting population health. And if they decide that it is, they'll issue a recommendation. And then it becomes up to the states, the 50 states, to integrate that information into their newborn screening programs. Some states need to actually amend legislation in order to add a new test to the newborn screening panel. Some of them need to work with their state labs of hygiene to make sure that assays can get executed as they're supposed to, so on and so forth. But this is kind of the well-traveled path that we've been down with genetics and newborn screening. When we look at the contemporary developments, there are all these new genetic tests. It seems like every time you open the newspaper, you hear about a new genetic marker for some kind of disease, whether it's prostate cancer or heart disease or restless leg syndrome, whatever is out there. There's more than 2,000 of them now, and a lot of these are marketed directly to providers or directly to consumers. And there isn't yet a parallel process that will help providers and consumers vet whether or not they're useful in population health. So one of the things that some states have started to do is respond to some of this direct-to-consumer marketing. One of the things that first got me interested in this question was in New England, the state health agencies in New York, Connecticut, and Massachusetts learned that Myriad, which is the company that owns the BRCA test for the breast cancer gene, they learned that Myriad was going to be moving into New England with a direct-to-consumer ad campaign. And they said, well, this is really kind of bad. We don't think that all women should be tested for the BRCA gene. It's only appropriate for some women who have a particular family history, a particular set of risk factors. And this is kind of just an effort to make a lot of money off people who wouldn't necessarily benefit from that test. So what these state health departments did was they crafted a counter campaign that educated people about the appropriate use of that screening test. So what is considered a strong family history for breast cancer? and who should be screened for this disease, and how might it be useful. And then they distributed that information to the public and then also to healthcare providers through their state medical societies. So this is an example, it's almost kind of a negative example of where a state agency is saying, well, before we get to the question of should we implement this stuff in surveillance programs, this is a case of a state agency saying, you know what, that's really a premature use of the technology. We know that we're going to need to be there and need to be able to make decisions like this, but this particular test is not ready for prime time yet. So that's one example in the assessment realm. In the realm of assurance, this is something that I've already kind of alluded to with respect to workforce development. So as genetics is growing, it becomes important to more and more patients, and we need more and more healthcare providers who are appropriately trained to help people decide whether or not they should have a genetic test and how to interpret that information to guide their health. We've encountered a problem because third-party healthcare insurance companies will often only reimburse for care that's provided by a licensed provider. So there are these master's-trained genetics counselors who get training in genetics and counseling psychology, and they're trained in how to do this with patients. But although they have a board exam, certified by their national certifying board agency, if they're not also licensed at the state level, they're going to have a hard time getting reimbursed for the care that they deliver. Now, because they're going to have a hard time getting reimbursed for care that they deliver, it means that the healthcare system or the doctor's office that they work in is going to take a loss on that service. And that's a big barrier to hiring genetics counselors. This is one of the things that the genetics counseling profession has been trying to push for, getting state health agencies to issue licenses, and they can define minimum qualifications and then issue those licenses to genetics counselors. So as of right now, about 8 states have begun to issue licenses, and about 5 states are in the process of drafting regulations. So this is an example of, again, a diffusion question. So how do states cooperate? How do they learn from one another? Do they borrow regulations? Do they write their own from scratch? So on and so forth. So one of the things I'm interested here then is how policy diffuses across formal and informal networks. So I gave you an example earlier of an informal network. So New York, Connecticut, and Massachusetts learn that there's this ad campaign, and they decide to get together and cooperate on a short-term project that's going to help population health in their region. So that's an example of an informal network. But there are also more formal organizations that bring state health agency officials together to cooperate. So groups like the Council of State and Territorial Epidemiologists, or the National Association of City and County Health Officials, the Association of State and Territorial Health Officers. People who work in these agencies, they all belong to professional organizations that periodically bring them together to talk about common challenges and common problems that they face. And they become a venue where people can collaborate and share information, and possibly share information that will impact programming and policy. So scientific professional organizations, some of the national organizations that I mentioned professionally. So the 5 states that I'm going to be studying, I've already completed work on Wisconsin. I've been studying Wisconsin's public health genetics programs for 2 years. The NIH grant is going to allow me to add 4 more cases, 4 more states to this study: Michigan, Connecticut, New York, and Utah. And you may ask why those states. So I've selected those states to focus attention on things that I think are likely to vary and things that I think are likely to affect the scope or the direction or the content of public health genetics programming in those states. Things like financing and leadership. We know that financing is going to be very important. So the amount of money that a state can devote to a particular kind of program. We know that leadership is really important. So having a charismatic leader to champion a program is going to be really important. But to some extent, that becomes sort of a less than satisfying explanation at a policy level, that we just need to throw more money at the problem, or we just need to wait until the right person comes along. So I think there are other things probably going on that are worth examining. Things like state health agency structure. Does it matter where in the state health agency the genetics program resides? So here in Wisconsin, it's organized with the maternal and child health programs, but in New York, it's part of the chronic disease and prevention program. And does that matter to how broadly they think about genetics and public health and who should be subjected and who should benefit from these kinds of policies? Another thing that I think is really important, I've already alluded to, participation in formal and informal networks. And then finally, I'm interested in how states are talking about the conceptual frameworks that are guiding their programming decisions. So are they concerned about things like health inequalities? Are they concerned about genetics across the lifespan? And how do those conceptual frameworks and discourses actually feed into the sorts of programs that they're developing? My analytic approach is going to be, this is a comparative case study. So just as in medicine, medicine will use individual case studies of particular patients to help understand something about the natural progression of disease. A comparative case study will help to clarify patterns that can end up leading to similar kinds of outcomes. So in epidemiologic terms, this is kind of like in epidemiology when you shift from doing a descriptive study to a case control study, so to speak. And in this kind of study, it helps us decide which factors are most important in garnering program development, and then clarify how those factors can interact with one another. This is a method and a technique that is very familiar in sociology and in political science. Theda Skocpol wrote a book called States and Social Revolutions, in which she used this method to disentangle the different factors that led to the French Revolution, the Russian Revolution, and the Chinese Revolution. More recently, it has started to penetrate into health services research. So there was a special issue of HSR in 1999 that looked at barriers to adopting telehealth in rural communities, or how predictors of patient safety in large capitated HMOs. So it's becoming a method that is a little bit more common in health services research. My data collection and analytic plans, mainly this is a qualitative study. I'm using some field observation, archival research. So a lot of these state health agencies have published information about their programs and made it available on the web. I'm downloading all of that information to document what they've done and changed over time. And then I'm spending a lot of time interviewing state policymakers to ask them, how did you make decisions? In a tightly budgeted environment, how did you weigh trade-offs in the kinds of things that you could invest your resources in? But I also recognize that the state health agencies don't work alone. And in limited budget environments, public-private partnerships are really important, so I'm talking to all of their external stakeholders. Here in Wisconsin, I've spent a lot of time talking to clinicians, talking to people from the consumer advocacy groups or the patient support groups that represent patients who have genetic diseases, and asking them, how do you feel about what the state is doing in genetics? I'm also talking with experts at the national level and on the state level who are knowledgeable about sort of cutting-edge science. Where's the science going to go next, and how do you think it's likely to impact state policy? And then analytically, you start in this kind of method with within state descriptive analysis. So you start doing role ordered displays, for example, to help understand how stakeholders relate to one another. You chart things across time to understand, are there critical instances or there critical junctures in program development that kind of led a state to one sort of solutions rather than another. And then once you've done the descriptive analysis, you can do cross-state comparisons, looking at what the common factors are across states, and then what are the common processes that states go through on this evolutionary path. So my K Awards started in July. As you may know, the K includes money or resources for additional training, research, and protected time to write an R01. So my training is going to take me, give me some additional work in genetics, public policy, and public health ethics. And then for my research, I'm going to be starting data collection in Michigan and Utah later this year. From my pilot research, as I said, I've completed data collection in Wisconsin. I've got 2 manuscripts in development right now. One looking at access to genetic services in rural and urban Wisconsin. That's in preparation for health affairs. And then one about health insurance coverage for genetic services. And that I want to send to genetics and medicine. So what I want to do right now is just preview some of my pilot data. I'm just going to show you a little bit of what I've learned in Wisconsin. And then as I walk you through these, I'm going to preview what I think some of the interesting comparisons are going to be with the cases and the states that I'm traveling to. So in 2001, Wisconsin had a grant from HRSA, the Health Resources Services Administration, to do a strategic plan around genetics in Wisconsin. This was one of the goals that was articulated in that plan. And it said that outreach activities have been and remain a central part of genetic care in Wisconsin. Such outreach not only provides services near the communities in which families live, but also strive to provide the quality of access to services and to function as a safety net for families who would otherwise be without this help. So the state has for decades underwritten provision of genetic services in rural communities. So the state health department will put a geneticist on a plane and fly him up to Superior for a couple of days, 3 or 4 times a year, so that if you're living up in northern Wisconsin and you've got a kid with cystic fibrosis, you don't have to drive 5 hours to get down to Madison. So this is one of the ways that the Wisconsin has chosen to use its resources to help communities access genetic programs and genetic services. One of the things that's really interesting to me here is that the very, very explicit reference to health inequalities and concern about the rural-urban problem of access. So many specialty care services like genetics are concentrated around big academic medical centers or in big cities. And at the time they wrote this plan, they were really concerned about, well, what are we going to do? How are we going to help serve people who live upstate? And this was one of the solutions that they came to. So I've spent some time kind of documenting and charting the way this healthcare system that they developed worked. What this figure shows is how they're financing these programs. So the top panel shows the grant that Wisconsin receives from HRSA for the Title V Maternal Child Health Block Grant. So as you can see, since 1989, it's hovered somewhere between $10 and $11 million. In the lower part of this panel, you'll see what they've invested in these genetic outreach clinics over time. And you'll see that it's been a very small proportion, but also that over time it has declined disproportionately to the rest of the HRSA maternal child health allotment. And this is one of the challenges that states face, with discretionary programs like this, when there are a lot of other demands on the maternal child health program for family planning, for children and youth with special health care needs, things that are mandated either by state legislative initiative or through HRSA regulations. When it comes to funding other things that are more discretionary, there's a lot of pressure on those programs. So as I've already alluded, I just wanted to give you a sense of where these outreach clinics are located, because their locations have changed pretty dramatically over time. So in 2004, when they first started, they had been running them for a couple of decades, but in 2004, outreach clinics were located a lot of upstate communities, so La Crosse, Superior, Ashland, Fond du Lac. And then in 2005, they instituted a change in their contracting, and rather than contracting with an academic medical center, they started contracting with a private, not-for-profit healthcare system that was based in Milwaukee. And when they made this change, they talked very explicitly about their concern about health inequalities attributable to racial and ethnic minorities, or attributable to differences in the racial and ethnic composition of different communities. And they wanted to try to do a better job reaching out to communities in southeastern Wisconsin. So they started changing clinic locations and concentrating them in Milwaukee, Kenosha, Racine. So this map here that I just showed shows population density. So they were trying to concentrate clinics in places where a lot of people live. And they were trying to concentrate clinics in places where a lot of racial and ethnic minority populations in Wisconsin live. One of the things that I think is an interesting question then is how effective were they at reaching out to and enrolling and serving people in these communities. This just shows a little bit about the patient volume. So on the left-hand vertical axis are the number of patients seen in these outreach clinics over time. And on the right-hand vertical axis is the number of clinic days that they've been active in various locations around the state. The dotted line here shows when the contracting shift took place, so when they turned over management of the contract from an academic medical center to the Milwaukee-based private not-for-profit. And I think what you'll see is that in terms of the number of patients served, there's been a really steep decline in the number of people that they've been able to serve in these outreach clinics. And part of that may be attributable to the location and where the clinics were, but part of it is also attributable to the declining budget and the restrained amount of resources that they can devote to outreach activities. This is a very crude analysis that I just wanted to ask about, well, if they're trying to relocate in these communities where racial and ethnic minorities live, are they doing a better job reaching out to and enrolling people from racial and ethnic minorities? The gray bar shows the outreach clinic patient population, and the black bar shows the Wisconsin population according to the U.S. Census. And you'll see that before the shift in locations occurred, there were really no differences in the profile of the patients that they were seeing in the outreach clinics vis-a-vis the population at large. After the clinic shifted, they did much better enrolling Latino populations in the outreach clinics than they had previously. I did a similar analysis to this looking at the racial composition of outreach clinic patients compared to the Wisconsin population at large, and I didn't find a comparable shift. So one of the things this suggests to me is that when they relocated their clinic locations to the Milwaukee area, they were able to increase their outreach to the Hispanic community, but probably not to the African American community. And I think that raises a bunch of questions for the program administrators. You know, why was that, and are there things we can be doing or should be doing differently to improve the way we provide services? So with an assurance, you know, one of the things that I have learned from talking with all the stakeholders in this project is that the way organizations relate to one another in these public-private partnerships really matters. So, you know, in the responsibility for these outreach clinics has been shared over time between the academic medical centers and these private healthcare systems, both of which I think have over time faced tensions between what I call mission-driven medicine and profit-driven medicine. And in my qualitative interviews with the people who participate in these programs, they would say things like, this is from a person who was active in the program back in its early days when it was first started by the university. They would say, well, we just did this under our salaries from the university. You know, we would get a university car. You know, we never charged for these services. You know, we had salaries. We did what we did. So they would say, okay, if we bring a family to you at one of these outreach clinics, what does it cost? And I would say nothing, because we had our salaries. It was ideal and it was stupid, but there was money in those days. And when I talked with people in the private, not-for-profit healthcare system about their motivations in providing care through these genetic outreach clinics, the hospital administrator tells me, you either got to make me rich or make me famous. So in a different environment, they're faced with really different kinds of messages about how they should be spending their time. One of the things that has definitely changed over time, though, is that the university and the academic medical center clinicians are starting to feel the same kinds of pressures. So one of them said to me, there's another way of looking at outreach. We were very intent on having these things be community-based. You know, who's here who can provide these services that your child needs? What's the easiest, least inconvenient place we can send you where you can get those? Whereas now when we do outreach, the unstated goal is just to refer kids back to our own hospital. So, you know, when I go to an outreach clinic, the understanding is that if the kid is going to need to see a cardiologist, they're going to see one of ours. So as I described earlier, you know, genetics providers, you know, if they're not licensed, they can't get reimbursement. This is a money-losing proposition for a lot of these healthcare systems. But this is how they're going to try to recover and make economic sense of it, is try to recover some of that downstream revenue. So there's pressure on the clinicians when they're serving people in these outreach clinics. You know, it's no longer just about what's easiest for the patient, but there's going to have to be some kind of a payback for the healthcare system. So I want to wrap up here so that we have some time for questions. What I think I've learned here about the challenges that Wisconsin is facing and how it's going to inform what I'm going to be looking for in the other states. Clearly, Wisconsin has faced a lot of difficulty maintaining support for what is really a discretionary program. And I think that this is not going to be unique, but I think I'm going to probably hear different stories about how different states are supporting their programs financially. So Wisconsin has been paying for it out of their maternal child health block grant. Some states I know have had grant support from the CDC. Some states have tried to take it out of their general program revenue. So I think that the source of the funding is likely to really matter. One of the things that people in Wisconsin have said to me is, well, we would love to do stuff about adult onset cancers, but we're situated in the Maternal Child Health Bureau, and we're paying for this with our Maternal Child Health Block Grant, so we really have to, you know, restrict our focus to moms and babies. So in Wisconsin, they've really had to worry a lot about the spatial mismatch. So where are genetic services located in terms of different academic medical centers or urban centers, and how do we help to reach out to populations in urban areas that are not well served by those systems, or in rural communities? It's definitely been an issue in Wisconsin. I know that it's going to be an issue in Utah when we get to the Utah case. If you've ever seen a population density map of Utah, it looks pretty amazing. And then the other thing that I'm really hearing from the Wisconsin folks is that these interinstitutional relationships really matter, and that they're going to change over time. And as institutions respond to the economic climate that they're in, the way they relate to their institutional partners is also going to change. So getting a better understanding of how organizations relate to one another and how those relationships change over time, I think is going to be very interesting. As I've already suggested, moving out to other states, structural comparisons are going to be important for me to look for. So New York's programs are situated in the Department of Chronic Disease Prevention. I think that will likely have an impact on their willingness and their ability to serve, for example, adult onset cancers, or address questions about other kinds of disease conditions. And then, as I've suggested, the conceptual frameworks that are guiding program development are very interesting to me. So the extent to which they talk really explicitly about this as a problem of health inequalities, or do they? And how do they match that rhetoric and that concern for health inequalities with how they're actually evaluating, and whether they're evaluating the success of their programs in meeting those objectives. I'm also interested in this idea of the life course, which is increasingly important in genetic epidemiology. So this idea, and in other branches of epidemiology too, certainly, but the idea that your genetic endowment at birth is going to affect health over the course of your life and will contribute to different kinds of health conditions over your life course. That's a little bit different than saying that you may also be at risk for an adult onset cancer because of some sort of a genetic risk factor. So life course is one of those terms that gets kind of tossed around a lot, but in a multidisciplinary environment like public health or like a state health agency, it's going to mean different things to different people. And one of the things I'm already seeing is that this is a point of contention. Coming to agreement about the idea of the life course, or coming to agreement about the problem of health inequalities, and then letting that guide program development is going to vary. In terms of the contributions, I hope that this is going to identify factors that will enhance capacity in public health genomics across states, and then also clarify which elements may be unique or would work only in a particular state, and that these findings would be valuable to state policymakers, the federal agencies that support them. And I'm also hoping that ultimately it will lead us towards a model for understanding how public health responds to emerging public health problems. So we've seen it happen a number of times in the past decade. Public health has had to deal with bioterrorism, with emergency preparedness, now with genetics. So hopefully by studying an emerging public health problem as it's unfolding, we're going to understand how state agencies come to these solutions. On the theoretical side, I am also a social scientist, and my sociology colleagues are interested in how policy innovations diffuse across state borders. I'm interested in this process of research translation. So looking not just at the intersection of science and politics in the creation of scientific knowledge, but how do organizational or professional or political actors influence what happens in research translation. Part of the K application is you need to sort of specify what other kinds of research you see coming out of this project. So as an initial step, I'm going to be looking at what the state health agencies are doing. I think there's a subsequent set of questions about how local and county health agencies are playing a role in this research translation network. I think that it's also worth interrogating the role that schools of medicine and public health have in these questions about workforce preparedness. How well are we preparing the next generation of healthcare providers to make use of genetic information in ways that are equitable, ethical, and cost-effective? And then finally, I think that when we get to the very far right-hand side of this, looking at whether or not any of this actually matters for population health and for health outcomes. I wanted to leave some time for questions. There's probably a lot more that I could say, but I'd be interested in hearing your thoughts about kind of where I am right now with this project.